students, I'm Dr. Sakshi Hans and today I am here with you to discuss the questions which were asked in the recent Fmge exam which was held on 18th of June 2021. So we'll be doing a recall of all the obs and gynae questions which were asked in your Fmge exam. There were a good number of questions from obs and gynae. Around 28 to 30 questions were asked from obs and gynae, and the questions was, they were very balanced set of questions where you had single liner questions as well and you had clinical questions also. But the good point was that all the questions were from those topics which are very high yielding topics, and we've always been telling you regularly in classes to revise those topics, right? So let's begin our today's discussion. The first question was, an intern conducts a delivery. Immediately after delivery, mother experiences breathlessness. She experiences hypotension, tachycardia, and she collapses, right? So it is a case of postpartum collapse. So immediately after delivery, the female is collapsing. Now, before I go ahead, quickly tell me what are the three very important causes of postpartum shock or postpartum collapse. We've done this in class so many times. You know it is PPH. Number two, it could be a case of uterine inversion, right? And number three, it could be a case of amniotic fluid embolism, right? Now, per vaginal examination is normal and there is no excessive bleeding. Now, bachcho, if there is no excessive bleeding, can it be a case of PPH? No, it cannot be a case of PPH, right? Per vaginal examination is normal. Now, if per vaginal examination is normal, that rules out uterine inversion. Why? Because what is uterine inversion? Uterine inversion is that initially the fundus of the uterus dips. So suppose you are giving traction to the cord, you are pulling the cord before the placenta has separated. Now what is going to happen? The placenta has not separated from the uterus, but you are pulling the cord. So what is going to happen? The uterus is going to come out along with the placenta, and that is exactly what is uterine inversion. Now if uterine inversion is to the extent that the entire uterus lies outside vagina, it's very easy to identify it. But sometimes uterine inversion is not to that extent. The extent is that there is dipping of the fundus. And when this fundus dips, it can be felt as a rounded mass in filling the vagina, right? So in case of uterine inversion, on per vaginal examination, you are going to feel a rounded mass which is present inside the vagina. And because in this case it is given that per vaginal examination is normal, that rules out uterine inversion. Not only this, in case of uterine inversion and in case of PPH, yes, bleeding will be present, so patient will be in shock. But it doesn't explain that why is there breathlessness, right? Whenever you are getting that there is a female who is having postpartum collapse or shock and you are getting breathlessness along with it. So there is this term breathlessness mentioned. Immediately you should think about amniotic fluid embolism. But so amniotic fluid embolism, it is a diagnosis of exclusion. It is a clinical diagnosis which has to be made once you have excluded PPH and once you have excluded out uterine inversion, right? So here I have a table for you in which we have written down important distinguishing features between PPH, uterine inversion and amniotic fluid embolism. When we talk about the time of occurrence, see, we are talking about primary PPH over here, which is happening immediately after delivery, and primary PPH can happen up till 24 hours of delivery. When we are talking about uterine inversion leading to postpartum collapse, we are talking about acute uterine inversion, and again acute uterine inversion, it occurs within 24 hours of delivery. But when we talk about amniotic fluid embolism, it happens at the time of delivery or it happens within 30 minutes of delivery. That's very, very important, right? So amniotic fluid embolism is not going to happen 2 hours after delivery or 4 hours after delivery. It is going to happen at the time of delivery or within 30 minutes of delivery. Now, what is the presenting complaint in all these three conditions? Although all these three can present to you with postpartum shock or postpartum collapse, but the presenting complaint in all these three can help you in finding out what is the cause of that postpartum collapse. In case of PPH, the presenting complaint is going to be excessive bleeding. Similarly, in case of uterine inversion, the presenting complaint will be shock. There will be bleeding, but the presenting complaint will be shock, right? So much so that the shock will be out of proportion to the blood loss. Because in uterine inversion, when you pull the cord and the uterus inverts, initially there is a neurogenic shock. So initially patient goes into shock and that is a neurogenic shock. Later on it is followed by hemorrhagic shock. So the blood loss will be less, but the shock will be more in comparison to blood loss. Whereas in case of amniotic fluid embolism, the first phase, initially the complaints which you get are, cardiorespiratory failure, are those of cardiorespiratory failure, which means patient is going to be hypotensive, there will be tachycardia and there will be breathlessness, right? So initially you are going to get hypotension, tachycardia and breathlessness. Now, if patient survives this first phase, then she goes into second phase and that is the phase of DIC where due to excessive blood loss, patient is going to have DIC. But initially the first phase is of cardiorespiratory failure, right? Now, when you are going to do a per abdominal examination, since the most common cause of primary PPH is atonic uterus, so mostly in case of PPH, the uterus is not palpable, right? Because the tone of the uterus is lost. Whereas in case of uterine inversion, you are going to, because the fundus of the uterus has dipped, right? As I told you, the fundus of the uterus dips in case of uterine inversion. So when you will do a per abdominal examination, just below the umbilicus, you are going to feel a cup-like depression, right? So there will be a cup-like depression below the umbilicus. Why below the umbilicus? Because immediately after delivery, that is the place where the uterus is. So immediately after delivery, uterus is just below the umbilicus, right? Whereas in case of amniotic fluid embolism, the tone of the uterus will be normal and uterus will be normally palpable. There won't be any cup-like depression, right? Then comes per vaginal examination. In case of PPH, on per vaginal examination, you are going to get excessive blood loss. In case of uterine inversion, you are going to get a rounded mass filling the vagina and yes, bleeding would be present. Whereas in case of amniotic fluid embolism, there will be bleeding, but that is the second phase, right? In the initial phase, the bleeding is not there. It is very less bleeding in the first phase. First phase is more about cardiorespiratory failure. So per vaginal examination is normal, right? And so in our case over here, we are getting that the patient is having breathlessness, there is hypotension, tachycardia and she collapses. Per vaginal examination is normal and there is no excessive blood loss. What is the most probable diagnosis? The most probable diagnosis is amniotic fluid embolism, right? Now, there are a few students who told me that, ma'am, the question was not this. The question was that there is a female who delivers and she immediately goes into shock. There wasn't a mention of breathlessness. Now, if the question was that a patient goes immediately into shock after delivery and the term breathlessness has not been mentioned there, nothing else has been mentioned there, then repeatedly I have told you, then then your answer will be uterine inversion. So if there is nothing else mentioned, simply patient goes into shock immediately after delivery, then it's a case of uterine inversion, because in case of uterine inversion, patient immediately goes into shock due to neurogenic shock. Right? Just one thing which I want to tell over here more is that in case of uterine inversion, initially the patient goes into shock, that is because of neurogenic shock, but death happens in uterine inversion because of hemorrhage, because of hemorrhagic shock. Right? So let's see our next question. Pelvis associated with persistent occipito-posterior position. And I'm sure all of you did this question right. So very oftenly I have told you that if you are getting that occipito-posterior position is more common in. So if you are getting simply occipito-posterior position, there is no prefix attached to it, just occipito-posterior position, then remember that the most common pelvis which is associated with occipito-posterior position is android pelvis, right? But on the other hand, if there is a prefix attached to occipito-posterior position, for example, if there is persistent occipito-posterior position, or if your question is direct occipito-posterior position, the moment these two words are added in front of occipito-posterior position, your answer changes from android pelvis to anthropoid pelvis. And this we have done in our marrow modules also, right? So let's quickly revise the Cadwell-Malloy classification. According to the Cadwell-Malloy classification, there are 4 types of pelvis: the gynaecoid pelvis, android, anthropoid and platyploid pelvis, in which the most common variety is the gynaecoid pelvis, which is the most favorable for delivery as well. When we are talking about android pelvis, it is a male kind of a pelvis where the shape of the inlet is heart-shaped, as you can see from the image over here. In android pelvis, the ischial spines are very prominent and the side walls are convergent. Now, in android pelvis, here occipito-posterior position is most common in which kind of pelvis? It is most commonly seen in android pelvis, and deep transverse arrest is also more common in android pelvis because the ischial spines are very, very prominent. Right? Then comes anthropoid pelvis. Anthropoid pelvis is ape-like pelvis. This is the only pelvis in which the AP diameter of the pelvis is more than the transverse diameter. Right? So if they ask you persistent occipito-posterior position is more common in, or direct occipito-posterior position is more common in, then your answer has to be anthropoid pelvis. Not only this, if they ask you face to pubes delivery is seen in which kind of pelvis? So face to pubes delivery is seen in anthropoid pelvis. Anthropoid pelvis is the deepest pelvis also. Then comes the rarest variety of pelvis, which is the platyploid pelvis. A platyploid pelvis is a flat or a bowl-shaped pelvis. As you can see over here, the transverse diameter is more, but it is much more than AP diameter. So if they ask you in which pelvis is transverse diameter much more than AP diameter, it has to be a platyploid pelvis. Whereas in case of gynaecoid pelvis also, the transverse diameter is more than AP diameter, but it is not much more than AP diameter. Similarly, in android pelvis also the transverse diameter is more than AP diameter, but it is not much more. Right? So specifically, if your question asks you in which pelvis is transverse diameter much more than AP diameter, it has to be a platyploid pelvis. Platyploid pelvis, if they ask you that face presentation is most common in, or bro presentation is most common in, or transverse lie is most common in which kind of pelvis, then it is the platyploid pelvis. Platyploid pelvis is the shallowest kind of pelvis also, right? Now this is one place where you all confuse. If they ask you face to pubes delivery is more common in, face to pubes delivery is more common in anthropoid pelvis. But if they ask you face presentation is more common in, or bro presentation is more common in, then your answer is platypilloid pelvis. Face to pubes delivery means that the face of the baby is facing towards the pubic symphysis, right? So that is face to pubes delivery, and that is what is more common in anthropoid pelvis. Face presentation is more common in platypilloid pelvis, right? Just one or two, another single liners which I want you to quickly revise with me in case of occipito-posterior position. If they ask you what is the most common cause of occipito-posterior position, they are not asking you the pelvis, but overall they are asking you what is the most common cause of occipito-posterior position, then also your answer is android pelvis. If they ask you what is the second most common cause of occipito-posterior position, then it is deflexed head. What is the best management of occipito-posterior position? It is wait and watch. Most of the times the head of the baby will spontaneously rotate and vaginal delivery will happen. Which is the most common occipito-posterior position? It is the right occipito-posterior position which is the most common, right? Okay, let's see the next question. A female has previous history of cesarean section and prolonged labor. So there is a previous history of cesarean section and she is undergoing vaginal delivery, and in this vaginal delivery there is prolonged labor. She is hypotensive, fetal heart sounds cannot be heard, and fetal parts are palpable superficially. The likely diagnosis is. Now, one very important complication which you have to remember, that if there is a previous cesarean section patient who's undergoing vaginal delivery, which is called as VBAC, that is vaginal birth after cesarean, or it is also called as trial of scar. Now, in case of VBAC or trial of scar, you have to be very, very careful with respect to uterine rupture, because that is one complication which I have to be very, very careful about. Right? And how does a patient of uterine rupture present to you? See, a patient of uterine rupture is going to present to you with pain in abdomen. There will be, fresh bleeding from whenever the uterus is going to rupture. There will be fresh bleeding from vagina. There will be hematuria. And what is going to happen? And because the fetus is going to lie in the peritoneal cavity, that is why fetal parts will be superficially palpable. And fetal heart sounds will be absent because obviously the fetus would be dead. Now, till now, when I was doing vaginal delivery, I was looking at the station of the fetal head. Now, once uterine rupture happens and the fetus is now lying in the peritoneal cavity, I will not be able to feel the fetal station, the station of the fetal head per vaginally. I will not be able to feel that, and that is what is called as loss of station of fetal head, which is a very, very specific sign of uterine rupture. So, on per vaginal examination, there will be loss of station of fetal head. Now, in this case, and yes, what will happen to the mother? Vitals of the mother. Obviously, if an organ ruptures, a mother has to go into shock. So, mother will be having tachycardia and hypotension. Right? What about the fetal heart rate? See, when the uterus is about to rupture, right, what we call as impending uterine rupture. So when uterus is about to rupture, there will be fetal heart rate changes, right? So fetal heart rate changes are going to happen, and the first change which you see, so when uterus is about to rupture, there will be hypoxia, and because of that hypoxia, in response to that hypoxia, you are going to get fetal tachycardia. Right, so the first heart change, fetal heart rate change which you see when uterus is about to rupture is fetal tachycardia. Later on, because of the continuous hypoxia, there will be fetal bradycardia. Later on, there will be fetal bradycardia. So if someone asks you that in case of an impending rupture, what is the first sign of, which you see, what is the change in fetal heart rate which you see? The first change in fetal heart rate which you see is fetal tachycardia. But most of the times this tachycardia is missed by the obstetricians, and by the time we detect that there is rupture, by that time fetal bradycardia happens. So the most common fetal heart rate change which is associated with rupture is fetal bradycardia. Right? So in this case, so there will be fetal bradycardia, and gradually once the rupture has happened totally, fetal heart sounds would be absent. So in this case over here, there is previous history of cesarean section, there is history of prolonged labor, and suddenly you are seeing that the mother has become hypotensive, fetal heart sounds fetal heart sounds cannot be heard, and fetal parts are palpable superficially. All these point out towards uterine rupture as the cause, right? Why it cannot be active labor? Now, in active labor, when a female is in labor, why is it that the fetal heart sounds will not be heard? So, absence of fetal heart sounds is going against active labor, number one. Number two, why will the fetal parts be felt superficially? So obviously it cannot be a case of active labor. Then why not hydramnios? Again, in case of hydramnios, why will you not hear the fetal heart sounds? And suppose, because of the excessive amniotic fluid, you are unable to hear the fetal heart sounds. Then why is it that the mother is having hypotension? Why is it that she is having tachycardia? And why is it that the fetal parts are palpable superficially? Right? Then why is it not a case of abruptio placenta? Now, it is not a case of abruptio placenta because generally abruptio is seen in case of PIH, right? So, in patients who are having abruptio, although they are having bleeding, still they are not hypotensive, right? Because most of the times patients are hypertensive, right? So, abruptio is a complication of PIH, number one. Number two, in case of abruptio, you get uterine tenderness. That is absolutely right. But the fetal parts will never be palpable superficially, right? The other very important distinguishing features between abruptio and uterine rupture, which you have to remember, are in uterine rupture also tenderness is present, but in uterine rupture it's a generalized tenderness. In case of abruptio, so please write these two things. In case of abruptio, you get uterine tenderness, right? The uterine tenderness will be present, whereas in case of rupture, you are going to get generalized tenderness, right? Number one. Number two, in case of abruptio, uterine contour is normal. Uterus is tensed, I agree. Uterus is rigid, I agree. But you will be able to feel the uterus perabdominally, right? Whereas in case of uterine rupture, uterine contour is lost, right? In case of rupture, mother will be having low BP. Right? In case of abruptio, most of the times mother has high BP or she will have normal BP. In case of rupture, fetal parts will be felt superficially. Fetal parts will be felt superficially. Right? Whereas in case of abruptio, fetal parts, they are not felt superficially. Right? So this is how you distinguish between abruptio and uterine rupture. And specifically over here, because she is a case of previous cesarean section and there is history of prolonged labor, this is a case of uterine rupture. Clear? Next question. A 32 weeks pregnant female complains of vaginal bleeding. So 32 weeks female coming to you with vaginal bleeding, it has to be a case of antepartum hemorrhage. On perabdominal examination, uterus is tender and fetal heart sounds are absent. Now tell me, now there is a case of antepartum hemorrhage where the uterus is tender, and just now I told you that in abruptio uterus will be tensed and it will be tender, and because uterus will be tensed and tender, that is why fetal heart sounds are not heard easily in case of abruptio. So I don't have the options for this question, but definitely the answer to this question is abruptio placenta, right? Now, question number 5. A pregnant female visits antenatal OPD for the first time at 18 weeks of pregnancy. Her fundal height corresponds to 16 weeks. So she is 18 weeks pregnant, but the height of the uterus is corresponding to 16 weeks. That means you are getting height of the uterus is less than the period of gestation. And what are the conditions in which height of the uterus is less than the period of gestation? Number 1, it can be a wrong dates, because of which the height is less. Number 2, it could be a case of oligohydramnios. Number 3, it could be intrauterine death of the fetus. And number 4, IUGR. In these conditions, the height of the uterus is less than the period of gestation. So the obstetrician advises ultrasound. Which of the following is likely to be seen on ultrasound? And your options were fetal renal agenesis, option A, option B, fetal anemia, option C, anencephaly, and option D, Barter's syndrome. Right? So now tell me, over here, what are you suspecting? Over here, I am suspecting that there is oligohydramnios. They haven't mentioned IUD or IUGR in the option, so I am not suspecting them. I am suspecting that there is oligohydramnios. And what is the reason for oligohydramnios? The most common reason for oligohydramnios is if fetus is producing less urine. And when will fetus produce less urine? Fetal will produce less urine if there is a renal defect in the fetus. Right? So if there is fetal renal agenesis. So on ultrasound, I am expecting that there is fetal renal agenesis, because of which there is oliguria, and that oliguria is leading to oligohydramnios. Right? Now, in case of anencephaly, what happens? In case of anencephaly, there is a swallowing defect. So all of you know that besides producing amniotic fluid, fetus also keeps amniotic fluid in balance by swallowing it. So in case of neural tube defect, that is anencephaly, there is a swallowing defect in the fetus, number 1. And number 2, because this vault is absent, the cranial vault of the fetus is absent, so CSF leaks into the amniotic fluid, because of which there is polyhydramnios and not oligohydramnios. Right? Now, what happens in fetal anemia? In case of fetal anemia, because fetus doesn't want a lot of load on the heart, that is why there is polyuria in fetal anemia. And because in fetal anemia there is polyuria, this polyuria will lead to polyhydramnios. So fetal anemia also leads to hydramnios, that is polyhydramnios. Right? Barter's syndrome. What is Barter's syndrome? Barter's syndrome, there is a problem in the kidney, so that there is salt and water wasting. So the salt is not reabsorbed. There is a problem in the tubular reabsorption over here. Now, because there is a problem in tubular reabsorption, so there is salt water wasting in the fetus, because of which again there is polyuria, and this polyuria is going to lead to polyhydramnios. Now, some students are saying that the option D was Barter's syndrome. Others are saying that the option D was hydrocephalus. Now, if option D was hydrocephalus, again in hydrocephalus, the head of the fetus is very much enlarged. And if head of the fetus is very much enlarged, it is going to lead to an increase in the height of the uterus and not to a decrease in the height of the uterus. Right? So, your answer remains fetal renal agenesis. Clear to all of you? Okay, next. A 25-year-old P1L1 delivered 12 weeks back, and she gives history of continuous heavy bleeding per vagina. She has history of dilatation and curettage in some private hospital. The most likely explanation for the bleeding is. Now over here, patient, she had delivery, and after delivery she had bleeding. And this delivery happened 12 weeks back, right? And because she had bleeding, she underwent a DNC also. But unfortunately, her bleeding hasn't stopped and she is still bleeding, right? Now, can you say that this is a case of normal lochia? No, this is not normal. This is something which doesn't happen normally. This is not lochia. Why? Because maximum, lochia is seen up till 24 to 36 days. That's maximum. Beyond this time, beyond 24 to 36 days after delivery, lochia is not seen. Right? Now, in this case, for the past 3 months, she is bleeding. So, definitely it cannot be lochia. That's ruled out. Number 2, is it a case of PPH? Now, if patient is having bleeding, right, after 24 hours of delivery, that is what is called as secondary PPH. And the most common cause of secondary PPH is retained placental tissue. And over here, in this case, patient has undergone DNC. So, if it would have been a case of secondary PPH due to retained placental tissue, bleeding should have stopped after DNC. But in this case over here, bleeding has not stopped after DNC. So, it is not a case of PPH. Right? Number 3, patient has developed DIC. Do you think DIC presents this way? That for the past 3 months, patient is having bleeding, she is going to a private hospital, then she is undergoing DNC, patient is absolutely fine except for bleeding, and she is coming to you with DIC? No, this doesn't happen. DIC is an acute event and the patient has to present to you immediately. Right? This is not the history of DIC. Okay, now that reminds me, some of you also told me that there was a question that what is the most common cause of DIC in obstetrical patients. So the most common cause of DIC in obstetrics is abruptio placenta. Remember that. If that was a question, that was a single line question. Very, very easy question, right? Option D is patient has developed gestational trophoblastic neoplasia. Yes. So most of the times gestational trophoblastic neoplasias, they develop after molar pregnancy, and that is why after H-mole evacuation we do a follow-up with beta HCG levels, right? That's the most common. But then gestational trophoblastic neoplasias can happen after normal delivery also, and that is something which we have been repeatedly telling you in class, that gestational trophoblastic neoplasia which develops after normal delivery is a high risk variety, right? Because after normal delivery, we do not do a beta HCG follow-up, and that is why they are detected at a late stage. So this patient over here who is having bleeding, continuous bleeding after delivery, DNC has been done and still the bleeding has not been controlled. Most probably she has developed gestational trophoblastic neoplasias. What are the signs and symptoms which should tell you that after H-mole evacuation or after delivery, patient has developed gestational trophoblastic neoplasia? Number 1, if patient is having persistent bleeding. So if patient is having persistent bleeding, that should bring your attention towards gestational trophoblastic neoplasia. Number 2, if there is subinvolution of the uterus. Number 3, if there is, signs of metastasis, and all of you know that choriocarcinoma, the most common site of metastasis is lung. So either there are signs of lung metastasis, and the second most common site is vagina. So or there is, signs of vaginal metastasis. So then you should think about gestational trophoblastic neoplasias. Right? Now, before I end this discussion over here related to this, there are 2 or 3 very important points which you have to remember. If suppose your question comes, question number 1, choriocarcinoma mostly occurs after. Right? So your question is, choriocarcinoma mostly occurs after. So most commonly choriocarcinoma occurs after H-mole evacuation. But if your question is that most common gestational trophoblastic neoplasia after H-mole evacuation, then your answer will not be choriocarcinoma. The most common gestational trophoblastic neoplasia after H-mole evacuation is invasive mole. Right? Third question. If your question is after full-term delivery, which is the most common gestational trophoblastic neoplasia? So which gestational trophoblastic neoplasia you should suspect after full-term vaginal delivery? Now your answer is choriocarcinoma. right? So these are the three very important single liners which I want you to remember. Okay. Next question. A 25-year-old primigravida female is on lithium for treatment of her psychiatric illness for past 2 years. The most common anomaly seen in the fetus whose mother is on lithium during pregnancy, and I know this, all of you know the answer, that it is Epstein anomaly. So just in this question, I want all of you to make a list of the drugs and what anomalies they can lead to if these drugs are consumed in the first trimester of pregnancy. Number one is lithium, and as the question told you that lithium leads to Epstein anomaly. What is Epstein anomaly? In Epstein anomaly, there is a malfunctioning or malformation of the tricuspid valve, right? Then warfarin. If female is taking warfarin in the first trimester, that leads to warfarin embryopathy. And in warfarin embryopathy, there is chondrodysplasia. That means there is a defective formation of the cartilages, and that presents as stippled epiphysis and nasal bone hypoplasia. So the cartilages are malformed in the baby if warfarin is taken in the first trimester, and that resembles chondrodysplasia, a condition, right? Then misoprostol. Now, if misoprost is taken in the first trimester of pregnancy, it leads to Mobius syndrome. In Mobius syndrome, you get 6th and 7th nerve palsy. Retinoic acid. If retinoic acid is taken in the first trimester of pregnancy, it leads to microtia or anotia. That means the external ear is small in the baby. Then thalidomide. If thalidomide is taken, then it leads to a condition called as phocomelia, in which the limbs of the baby are not formed, right? Alcohol. Now, if mother consumes alcohol in the first trimester of pregnancy, it leads to fetal alcohol syndrome. In fetal alcohol syndrome, you will get a triad, and that triad will have growth restriction, microcephaly, and there will be typical alcohol feces. In typical alcohol feces, the philtrum will be absent. This over here, the philtrum will be absent. They will be smooth over here. The vermilion border of the lips, the upper lip is going to be very thin, and the eyes are going to be very narrow, right? So these are typical features which are seen in mothers who consume alcohol in their babies. So you are going to get growth restriction, you are going to get microcephaly, and you are going to get these typical findings which include a smooth philtrum, then thin upper lip, and there will be small eye openings, right? Then phenytoin. So if phenytoin or any anti-epileptic drugs they are taken, like for example valproic acid is taken in pregnancy in the first trimester, so specifically I'm talking about valproic acid and phenytoin, then it leads to neural tube defects in the baby. Phenytoin leads to fetal Hayden-Toyne syndrome, and in fetal Hayden-Toyne syndrome you can have neural tube defect or they can be microcephaly. Apart from that, there will be cleft lip, cleft palate, and there will be underdeveloped fingernails nails of fingers and toes, right? So these are the features which are seen in fetal Hayden-Toyne syndrome. This is a very, very important table. Please note this table somewhere, so that next time, I am not saying that you're not going to clear your MCI exam, but these questions can be asked in your NEET PG exam also. I just hope that all of you who are listening to my lecture, all of you clear your MCI exam, and I meet you soon for your NEET PG preparation as well. Okay, next question. A 26-year-old female with mechanical valve and on warfarin therapy has her pregnancy test positive. The best advice to her is, and just now I told you, that if warfarin is consumed in the first trimester, it leads to chondrodysplasia, that is a contrary-like syndrome, and in chondrodysplasia, the cartilage of the baby is not formed, right? So there will be stippled epiphysis, there will be nasal bone hypoplasia as well. So if a mother who was having mechanical valves and she was on warfarin, and once she conceives, I know that in first trimester if she continues with warfarin, it can lead to warfarin embryopathy. So as an obstetrician, what am I going to do? I am going to switch her from warfarin to low molecular weight heparin. So option A is continue warfarin throughout pregnancy. That's wrong. Replace heparin with warfarin. Yes. And which heparin? It has to be a low molecular weight heparin. Discontinue all anticoagulants. That's absolutely wrong. See, pregnancy is a hypercoagulable state. That is why in pregnancy you cannot just say that stop all anticoagulants, right? Warfarin is contraindicated in pregnancy and lactation. No, please. Warfarin is not contraindicated in breastfeeding females. It's absolutely safe to give warfarin in breastfeeding females. So this is also incorrect. Remember that initially when a patient is going to come to you, so for 1 week to 12 weeks, up till 12 weeks, we are going to give her low molecular weight heparin, right? Because heparin doesn't cross the placenta and so it will not lead to any fetal congenital malformations. After 12 weeks, that is from the second trimester onwards and up till 36 weeks, I am going to put the patient back on warfarin. That is because pregnancy is a hypercoagulable state and it needs a very, very strong anticoagulant, right? So I have to put the patient back to warfarin. But again at 36 weeks, I am putting the patient back on heparin. Now at 36 weeks, again I am going to tell the patient that now you have to switch to heparin. That is because as I told you, warfarin can cross the placenta, right? Heparin doesn't cross the placenta. Now, because warfarin can cross the placenta, it can lead to anticoagulation in the fetus also, right? And at the time of delivery, when the fetus has to pass through the bony pelvis, right, the head of the fetus has to pass through very small space, that is the bony pelvis. And in that case, if the patient is on warfarin, the baby is also getting therapeutic levels of warfarin in blood, and that could lead to excessive bleeding in the fetal head. Right, so it can lead to intracranial hemorrhages in the fetus. Number one, that is the reason why we shift the patient from warfarin to heparin. Number two, heparin is not that strong an anticoagulant, right? So the chances of PPH in the patient herself are less because we have put the patient on heparin. And number three, there is an antagonist available for heparin. Right, so we have an antagonist for heparin. So these are the three reasons that why I'm going to shift the patient at 36 weeks from warfarin back to heparin. And that also explains that suppose patient doesn't come to me at 36 weeks and she is on warfarin and she goes into labor. What should I do? I shouldn't be doing a vaginal delivery, because if I do a vaginal delivery, there will be increased chances of intracranial hemorrhage in the baby. So if patient is on warfarin at the time of delivery, I have to take up the patient for cesarean section. Clear to all of you? All this we have discussed in Marrow videos and in our classes as well. Question number 9. The complication associated with IV bolus injection of oxytocin. Again, a single liner which we've done in class. I told you that whether you are managing PPH or whether you want to prevent PPH, that is in active management of third stage of labor, in both these situations, the first line drug is oxytocin. And oxytocin should always be given either intramuscularly or as IV infusion. You should never give oxytocin as IV bolus because it leads to hypotension. Initially, it will lead to hypotension in the mother, then there will be tachycardia, and later on it can lead to cardiac arrest, right? Another very important point which you have to remember whenever you are giving oxytocin as IV infusion is you should always give oxytocin in normal saline or ringer lactate, that is in electrolyte rich media. You should never give oxytocin in 5% dextrose, that is electrolyte deficient media. Why? That is because In case of PPH, you have to give oxytocin for a very long time. That means you will have to give a lot of fluids in case of PPH. Right? And in this case, if I am going to use electrolyte deficient media to give the oxytocin, it can lead to water intoxication, because oxytocin and antidiuretic hormone, both of them are released from posterior pituitary. So oxytocin itself has some antidiuretic properties. So there are two things which you will have to keep in mind. Never give oxytocin as IV bolus, because it can lead to hypotension. Number two, when you are giving oxytocin as IV infusion, never give it in dextrose 5% solution. Always give it in electrolyte rich media like ringer lactate or normal saline. Clear? Next question, false statement regarding the instrument shown in the images. And before your exams also, I had told you that you have to revise all the instruments, the video which I have taken on instruments in obs and gynae, that is available on Marrow Live channel. And specifically, I had shown this instrument there. This instrument which was shown in your exam is a manual vacuum aspiration syringe. How did I recognize that it is a manual vacuum aspiration syringe? Because it has got two pinch valves. So over here in this image, you can see there are two pinch valves. Whenever two pinch valves are present, it is a manual vacuum aspiration syringe. On the other hand, if there is a single pinch valve present, if there is a single pinch valve, then it is a menstrual regulation syringe. So unless and until you correctly identify the instrument, till that time you wouldn't have been able to answer this question. So this is a manual vacuum aspiration syringe. Manual vacuum aspiration syringe, as I have already told you, the capacity of the syringe is 60 cc or 60 ml. Number one. Number two, the pressure which is generated by manual vacuum aspiration syringe is 660 millimeters of mercury. If 660 millimeters of mercury is not given, then the second best answer is 600 millimeters of mercury. And number three, till when? What is the time limit till which you can do MTP with the help of manual vacuum aspiration syringe? With the help of manual vacuum aspiration syringe, MTP can be done up till 12 weeks of pregnancy, right? So over here, it creates a pressure of 650 millimeters of mercury. Yes, maximum volume is 65 ml. Sorry, in your options, it was written as maximum volume is 30 ml. This was the question which was given to you. So this was a wrong option. It can be used for MTP up till 12 weeks. Yes. It doesn't need electricity. Yes. See, ideally from 7 weeks to 12 weeks, the best method for doing MTP is suction evacuation with the help of a Carman's cannula, which is a plastic cannula. And you've all seen that cannula, that it has got two triangular openings. And this cannula is attached to a suction machine and you do the MTP. But in all those places where there is no electricity, for example, in rural settings, suction evacuation cannot be done. And in those cases, instead of doing suction evacuation, we use a manual vacuum aspiration syringe, right? So you all have to remember three things about manual vacuum aspiration syringe: that the capacity is 60 ml or 65 ml. Its pressure is 660 millimeters of mercury. If that's not given, then it is 600 millimeters of mercury. And by using manual vacuum aspiration syringe, MTP can be done up till 12 weeks. It doesn't need any electricity. On the other hand, if you look at the menstrual regulation syringe is a 50 ml syringe, and with the help of menstrual regulation, MTP can be done only up till 6 weeks of pregnancy. Whether they say 6 weeks of pregnancy or whether they say within 2 weeks of the missed period, it's one and the same thing, right? So you can use menstrual regulation syringe only up till 6 weeks of pregnancy or within 2 weeks of the missed period. Clear to all of you? Okay. Next question. A G4P0 plus 3 24-year-old female presents at 22 weeks with previous history of 3 mid-trimester abortions. On ultrasound, her cervical length is 20 mm. What could be the most probable cause of a recurrent pregnancy loss? So if a female is having 3 or more than 3 pregnancy losses, that is what is called as a recurrent pregnancy loss. Now, in order to call it as a recurrent pregnancy loss, either it has to be 3 or more than 3 pregnancy losses which are not confirmed by ultrasound or by histopathological examination. So these pregnancy losses are not confirmed by ultrasound or histopathological examination. Then we say that 3 or more than 3 losses. But suppose if pregnancy losses are confirmed by ultrasound, then only 2 losses are more than enough to call it as recurrent pregnancy loss. What do you understand by this? So suppose there is a pregnant female who says that, I had I did not have my periods for 6 weeks or 8 weeks. I did a urine pregnancy test. Urine pregnancy test was positive, but all of a sudden bleeding started. Right? I did not get any ultrasound done and no histopathological examination of the passage of clots was done. So in that case, you need 3 or more than 3 losses to call it as recurrent pregnancy loss. Right? But suppose there is a female who says that I had, a pregnancy of 8 weeks, which was confirmed on ultrasound, but then afterwards that it got aborted. Right? And similarly, second time I had a pregnancy of 10 weeks, it was confirmed on ultrasound and again bleeding started. Now in this female, even 2 pregnancy losses are more than enough to call it as recurrent pregnancy loss. Right? So in our patient, there are 3 mid-trimester abortions. So it is a case of recurrent pregnancy loss which is happening in mid-trimester. Right? So recurrent pregnancy loss which is happening in mid-trimester, right? That is in second trimester, and cervical length is 20 mm on ultrasound. So if in pregnancy the length of the cervix becomes less than 25 millimeters, that is what is diagnostic of cervical incompetency. Now over here there are 3 pregnancy losses, mid-trimester losses, and cervical length is less than 25 millimeters. All these definitely point towards cervical incompetence as your answer, right? Now in case of cervical incompetence, the question may also say that these were painless abortions. So all these things, if you are getting recurrent pregnancy loss which are happening in mid-trimester and the length of the cervix is less than 25 millimeters and patient says that there is painless abortion, these are typical things which are going to tell you that the answer is cervical incompetence. Clear to all of you? Okay. So let me quickly revise 1 or 2 other important points which I want to tell you. See, abortion, it can be a single episode of abortion or it could be a recurrent abortion. Just now I have told you the definitions for recurrent abortion. Now if they ask you what is the most common cause of single episode of abortion or a spontaneous abortion, your answer is chromosomal anomaly, whether the abortion is happening in first trimester or it is happening in second trimester. Most common cause of single episode of abortion either in first trimester or second trimester is chromosomal anomaly. And which chromosomal anomaly? It has to be an anomaly, a defect in the chromosome number. That is aneuploidy, right? But suppose aneuploidy is not given in the options, then the second best answer will be trisomy. Right? But if trisomy is also not given in the options, then it is monosomy X. And if monosomy X is also not given in the options, then your answer will be trisomy 16. Right? So you have to remember this in this order. The most common cause is your chromosomal anomalies, that is aneuploidy, or it will be written as a germplasm defect. Then after aneuploidy, the second best answer you have to look for is trisomy. Trisomy is a group. right? Trisomy means that there is one extra chromosome, and that extra chromosome could be chromosome number 16, it could be chromosome number 18, it could be chromosome number 21, it could be chromosome number 22. So as a group, the most common cause of abortion is trisomy. But if trisomy is not given, then you have to look for monosomy X, which is the most specific cause of single abortion. It's the most specific. If someone asks you the most specific cause of spontaneous abortion in first or second trimester, then your answer will be monosomy X. But suppose if monosomy X is also not given, then your answer will be trisomy 16. So suppose if you have to choose between monosomy X and trisomy 16 as the most common cause of abortion, then your answer, you should always choose it as monosomy X, because monosomy X leads to 20% cases of abortion, whereas trisomy 16 leads to 16% cases of abortion. Now let's talk about recurrent pregnancy losses. In recurrent pregnancy losses, the most common cause of recurrent pregnancy loss is uterine anomalies. And again, uterine anomaly is a group. Right? So in uterine anomaly, you can have congenital anomalies, you can have acquired anomalies. In congenital anomalies, you can have uterine malformations. Then you can have cervical incompetence. There can be a cervical fibroid, or there can be a uterine polyp. Right? So these can be the causes of abortion, uterine causes of abortion. So most common cause of recurrent abortions is uterine anomalies. But if I ask you, which is the single most important cause of recurrent pregnancy loss, then the single most cause will be APLA, anti-phospholipid antibody syndrome. So most common is uterine anomalies, but uterine anomalies is a group which includes many anomalies, which could be uterine malformations, which could be a fibroid, which could be cervical incompetence. But single most important cause which leads to recurrent pregnancy loss is APLA, that is anti-phospholipid antibody syndrome. Apart from this, endocrinal causes can also lead to recurrent pregnancy loss. Chromosomal anomalies can also lead to recurrent pregnancy loss, but when we talk about chromosomal anomalies, chromosomal anomalies lead to only 4% cases of recurrent pregnancy loss, and the most common chromosomal anomaly which leads to recurrent pregnancy loss, you are not going to say it is aneuploidy or trisomy. Most common chromosomal anomaly which leads to recurrent pregnancy loss is balanced translocation of chromosomes. Right? Now, as I told you, cervical incompetence, if they ask you what is the most common cause of mid-trimester recurrent pregnancy losses, then your answer will be cervical incompetence. Overall, if they are asking you most common cause of recurrent pregnancy loss, your answer will be uterine anomalies. If that is not given in the option, uterine anomaly term should be given. If that is not given, then it is APLA, right? And everything about cervical incompetence I have already told you. In cervical incompetence, patient is going to give you history of painless abortions. These painless recurrent abortions are going to be of mid-trimester, that is, they are going to be in second trimester. And most common time for abortion is 14 to 16 weeks, but it can happen any time between 16 to 24 weeks. And that is why if you are saying that your patient has got cervical incompetence, management becomes that you have to do a cervical cerclage. Cervical cerclage, the ideal time is between 14 to 16 weeks, but it can be done any time between 16 to 24 weeks. So this patient over here was coming to you at 22 weeks with previous history of 3 mid-trimester abortions. On ultrasound, cervical length is 20 millimeters. That definitely is an indication for doing cervical cerclage, right? Okay, next question. A 24-year-old primigravida is having pain in abdomen. Her cervix is 1 centimeter dilated and 20% effaced. After 10 hours, her findings are roughly the same, right? So suppose if your patient's dilatation is 1 centimeter, then definitely she is in latent phase of labor, or it could also means that there is false labor pains, right? Now, for all clinical questions, Bacho, you have to remember that active phase begins from 6 centimeters of dilatation. A WHO and partogram, only when the words like WHO or partogram are there, then you say that 4 centimeters is the beginning of active phase. But for all clinical questions, for all practical purposes, active phase begins at 6 centimeters of dilatation. Right? Now, in this question over here, primary gravida patient has been for 10 hours. Her cervix is 1 centimeters dilated. So, either it is, she's moving towards prolonged latent phase, or it could be that it is a case of false labor pains. Now, in order to differentiate between them, what I'm going to do is I'm going to sedate the patient. When you sedate the patient or when you give therapeutic rest to the patient, false labor pains, they subside. Whereas true labor pains, they do not subside, and once the patient is going to wake up, she will automatically be in active phase, or at least her dilatation would have progressed. So whenever you face a situation where the patient is in prolonged latent phase or she is moving towards prolonged latent phase, best management always is you should sedate the patient. Right, in order to differentiate between false labor pains and between prolonged latent phase. Clear? Next question. A 23-year-old primary gravida presents at 19 weeks of pregnancy for the first time. She has no significant medical history. Her family history is significant for diabetes running in the family. So she's coming to you at 19 weeks and there is history of diabetes in the family. Her ECG is normal, urine analysis is normal, fasting blood sugar is 126 milligrams per DL and HbA1c is 6.5. What is the diagnosis? So for diagnosing, gestational diabetes and for diagnosing pre-gestational diabetes, there are 2 types of diabetes. Either it could be a case of pre-gestational diabetes or it could be a case of gestational diabetes, right? Now, for diagnosing pre-gestational diabetes, the American Diabetes Association has given a criteria, and the criteria is if fasting blood sugar levels are more than equal to 126 milligrams per DL, or random blood sugar or 2 hours PP level. Either we are talking about random or 2 hour PP level. If it is more than equal to 200 milligrams per DL, or if HbA1c is more than equal to 6.5, then we say it is a case of pre-gestational diabetes or overt diabetes, which means that a diabetic female has conceived. On the other hand, for diagnosing gestational diabetes, the criteria which we use is DIPSI criteria. According to DIPSI criteria, I've already told you so many times in the lectures also, in the revision videos also, that whenever a patient comes to you for the first antenatal visit, irrespective of her previous meals and without any fasting, we give her 75 grams of glucose. Right? And after giving 75 grams of glucose, we check her blood sugar after 2 hours. If after 2 hours her blood sugar levels are more than equal to 140 but they are less than 200, then we say it is a case of gestational diabetes. Over here, when I'm saying that PP level is postprandial level. So here also the PP level which I'm talking about is after 2 hours of giving 75 grams of glucose, right? So American Diabetes Association criteria we follow for overt or pre-gestational diabetes, which is that fasting blood sugar levels, they should be more than equal to 126 milligrams per DL. 2 hour PP level after giving 75 grams of glucose, if it is more than 200, or random blood sugar are more than equal to 200, or HbA1c more than equal to 6.5. And over here, fasting blood sugar is 126 and HbA1c is 6.5. So it has to be a case of pre-gestational diabetes. Right? Please remember that for gestational diabetes, the criteria which is followed is DIPSI criteria. Right? Let's see question number 14. A 24-year-old female at 32 weeks of pregnancy has BP 160 by 116, which means that her BP is high. Her lab findings are significant for increased liver enzymes. Okay, increased liver enzymes, there is increased LDH, and there is decreased platelet count. What is your diagnosis? So I know all of you know the diagnosis, and the diagnosis is HELP syndrome. Now you are going to say that, ma'am, we agree that the liver enzymes are raised and low platelet count, but what about hemolysis? See, bacha, so many times in your questions you will not get directly term hemolysis. Instead of hemolysis, you can get any of these four. Right? So this is what is Tennessee's criteria, which I'm going to tell you to diagnose HELP syndrome. As per Tennessee's criteria, there has to be hemolysis, there has to be increased liver enzymes and low platelet count. But for hemolysis, any of the following two, if they are present, then you say it is hemolysis. And what are those? Number one, if instead of hemolysis, they say that on peripheral smear, you are getting schistocytes or Burr cells. So if you are getting cells like these on peripheral smear, right, number one. Number two, you all know that the degradation product of RBC is bilirubin. So if instead of saying hemolysis, your question says that the serum bilirubin levels of your patient are raised and they are more than 1.2, right? Number three, if your question is saying that there is increased LDH more than 2 times its normal value, or the levels of haptoglobin are decreased. And number four, it can say that there is severe anemia, microangiopathic hemolytic anemia. So if there is any of these four, right, then any two of these four, then we say that yes, hemolysis is present. Now, liver enzymes, LP is, EL is elevated liver enzymes, where the liver enzymes are raised to more than 2 times their normal value, and LP is low platelet count, that is platelet count less than 1 lakh. Right? So this is what is Tennessee's criteria for diagnosing HELP syndrome. This is a typical presentation of HELP syndrome, because in HELP syndrome, in 80 to 85% cases, BP of the patient is raised, and HELP syndrome is a complication of severe preeclampsia. Right? But I am saying that in 80 to 85% cases BP is raised, there will be around 15% cases in whom the BP of the patient will remain normal. But that doesn't mean that they cannot have HELP syndrome. But 85% cases may the BP of the patient will be raised. Right? So in this question, we are getting increased LDH. In this question, we are getting increased liver enzymes, and we are getting low platelet count and high PP. That leaves no doubt that the diagnosis is HELP syndrome. Let us see the other options. Why not the other options? Now, hepatitis. Why not hepatitis? Because in hepatitis, the liver enzymes are very high. Right, but there is no reason for low platelet count in hepatitis. And in hepatitis, patient is going to come to you with complaints of nausea, vomiting, anorexia. Right? In case of HELP syndrome, patient is going to come to you in third trimester, whereas in hepatitis, patient can come to you in any trimester. In case of HELP syndrome, in third trimester, patient is going to complain to you of pain in abdomen, which will be a right-sided pain, a right-sided epigastric pain. The patient is going to complain to you, right? In case of acute fatty liver of pregnancy, where number one, patient's BP is usually normal. It may be raised, but that is only in very small subset that the patient's BP is raised. Most of the times in acute fatty liver of pregnancy, patient's BP is normal, number one. Number two, in acute fatty liver of pregnancy, you get a hepatorenal syndrome, which means that you will not just get liver enzymes raised, you will get increased creatinine levels, you will get increased ammonia levels, and increased ammonia is going to lead to confusion in the patient, and there will be decreased glucose levels. Right? So you get hepatorenal syndrome in case of acute fatty liver of pregnancy. Rather, it is the most common cause of liver failure in pregnancy. Then comes cholestasis. Again, cholestasis also presents in third trimester, but the presenting feature of the patient is pruritus, which is more towards the palm and sole, and you get increase in bile acid levels. That's the marker for cholestasis, right? So over here, this patient is a case of HELP syndrome. right? And how do you manage HELLP syndrome? In management of HELLP syndrome, number one, because it's a complication of severe preeclampsia, so you will have to prevent them from having convulsions. So you will give them magnesium sulfate so that their convulsions are prevented, and you are going to do immediate termination of pregnancy irrespective of the gestational age. So magnesium sulfate and immediate termination of pregnancy, and if patient's BP is high, definitely you have to give them antihypertensives, right? Next question. Now we are going to talk about gynae questions. Which of the following curve or peak is responsible for ovulation? That's a very, very easy question. All of you know that it is the LH surge which is responsible for ovulation. So in other words, you have to recognize which peak is showing you LH peak or LH surge, right? So over here, this is the place where ovulation is happening. Now peak D is happening after ovulation. And which hormone's peak is attained after ovulation? It is progesterone. So that means peak D represents progesterone levels. And when are the progesterone levels highest? Progesterone levels are highest 8 days after ovulation, that is on day 22 of the cycle, right? So it is not peak D. Peak D is happening after ovulation. Now before ovulation, I can see 3 peaks, A, B and C. Amongst these 3 peaks, peak C and peak B are happening just before ovulation, right? So ovulation is happening because of either peak C or peak B, right? Now I am seeing that peak C is much higher than peak B. That means it is peak C which is representing LH, and this peak B is representing FSH. So this brings us to a point where I am going to tell you that yes, LH surge is responsible for ovulation, but bacho, please remember that before ovulation there is LH surge plus FSH surge. So it is not just LH surge which is happening before ovulation. Both LH and FSH surge happen before ovulation, but LH surge is the one which is responsible for ovulation, right? Now, why does LH surge happen? LH surge happens because the levels of estrogen increase in the body, and when the levels of estrogen, they become 200 picograms for 48 hours, then it leads to LH surge. So before LH surge, it is the estrogen peak which is going to happen. So that means peak A is representing estrogen. This is representing estrogen, right? So if your question says that which peak is responsible for LH surge, so it is peak A which is responsible for LH surge. LH surge is going to happen only when the estrogen levels are 200 picograms in the body for 48 hours. Then LH surge is going to happen, right? Now, if I ask you what is the time interval between LH surge and ovulation, your answer will be 32 to 36 hours, right? But if I ask you what is the time interval between LH peak and ovulation, then your answer will be 10 to 12 hours. So this is the point. This is the time interval between LH peak and ovulation. And this is the time interval between LH surge and ovulation. The place where LH starts increasing, that is LH surge, and the time gap between LH surge and ovulation is 32 to 36 hours, whereas time gap between LH peak and ovulation is 10 to 12 hours. That was a pretty easy question. Question number 16, again a single liner question. Identify the fibroid marked with X. Now what you are seeing over here is that there is a fibroid which is coming inside the cavity, and a fibroid which comes inside the cavity is a submucosal fibroid. Now submucosal fibroid, the answer is right, but over here what am I seeing? That this submucosal fibroid has a peduncle, right? So it is a pedunculated submucosal fibroid. A pedunculated submucosal fibroid. On the other hand, if I ask you what kind of fibroid is this? This fibroid is also going inside the uterine cavity, but it is a non-pedunculated submucosal fibroid, right? This over here This is an intramural fibroid, and the one which is growing towards the peritoneal cavity, that is a subserosal fibroid. So there are two subserosal fibroids which are shown in the diagram. This one is non-pedunculated, whereas this one is a pedunculated subserosal fibroid. Which is the most common kind of fibroid? The most common variety is intramural fibroid. Now, submucous fibroids, based on hysteroscopy, they are divided into three varieties, that as per Fmge classification: type 0, type 1 and type 2. Type 0 is the one which is marked as X. That means it is completely inside the uterine cavity. So a submucosal fibroid which is completely inside the uterine cavity is type 0. Whereas type 1 means that less than 50% is inside the myometrium, more than 50% is inside uterine cavity, and type 2 means the reverse. More than 50% is inside myometrium and less than 50% is inside uterine cavity. So this is your Fmge classification or hysteroscopic classification for submucous fibroids. Remember that type 0 and type 1 can be removed by hysteroscopy, whereas type 2 cannot be removed by hysteroscopy because more than 50% is inside the myometrium, right? Okay. Next question, identify the swelling seen in a 22-year-old female. Now over here it's a very easy question because you are seeing that the swelling is present in the posterior lateral wall of vagina. Whenever you see a swelling in the posterior lateral wall of vagina, it has to be a Bartholin cyst. Please remember that a Gartner's cyst is present in the anterolateral wall of vagina. Anterolateral wall of vagina. So suppose over here, this is your vagina, right? So any cyst which is present in the anterolateral wall, this over here, right? Anterolateral wall, that will be a Gartner's cyst. Any cyst which is present in the posterolateral wall, that will be a Bartholin cyst because this is the place where Bartholin glands ducts open. Where are the Bartholin glands located? They are located at 5 o'clock or 7 o'clock position. Some books also say 4 o'clock and 8 o'clock position. So obviously if Bartholin gland is located at 5 o'clock or 7 o'clock position, when the ducts of these glands will get blocked, they are going to present to you as swelling which will be present in the posterolateral wall of vagina. On the other hand, I want you to see this swelling. This swelling over here, this is the posterior wall where the Sims speculum is. Sims speculum is pressing down on the posterior wall. This swelling is present on the anterolateral wall of vagina. So if you would have got an image like this, this would have been a Gartner's cyst. Right? This over here is urethra. So if the swelling would have been in paraurethral glands, right, then the swelling would have been present somewhere here. Right, over here the swelling is present in the anterolateral wall of vagina. So this is a Gartner's cyst. See this image, all of you. Over here is the anterolateral wall of vagina. This is the posterolateral wall of vagina. So this red color is the Gartner's cyst and this blue color is the Bartholin gland cyst. Right? Clear to all of you? I hope you're never going to make any mistakes with with respect to diagnosing that it is a Bartholin cyst. Okay. Now, just before we go to the next question, one thing which I want to tell you about the management of Bartholin cyst because it has undergone an update. So remember, if Bartholin cyst is asymptomatic and it is less than 3 centimeters in size, then there is no treatment you have to give. You just have to tell the patient that she should take sitz bath, no surgical treatment you have to do, right? If Bartholin cyst is asymptomatic and it is more than 3 centimeters in size. Now earlier they used to say that the first line management of Bartholin cyst is marsupilization. But now they say that if the cyst is asymptomatic and if it is more than 3 centimeters in size, then the management is incision and drainage. right? You are not going to mark marsupialization as the answer. Incision and drainage and followed by placing a word catheter, right? Then, if it is a recurrent Bartholin cyst, if it is a recurrent Bartholin cyst, then your answer is that I am going to do a marsupialization, right? Suppose if your question says, what is the management of Bartholin abscess, any size? Bartholin abscess, again the management is incision and drainage, and again if it is a recurrent Bartholin abscess, then the management is marsupialization, and if marsupialization also fails, then it is excision of the gland, right? So these are the new guidelines which I want you to remember with respect to Bartholin cyst. Asymptomatic cyst less than 3 centimeters, no treatment needed, no surgical treatment needed. More than 3 centimeters, you have to go for incision and drainage. Recurrent Bartholin cyst is marsupialization. Management of Bartholin abscess is incision and drainage. Recurrent Bartholin abscess again is marsupialization. And if marsupialization also fails, then it is excision of the gland. What is the most common organism leading to Bartholin abscess? It is E. coli, right? Okay. Next question, the most cost-effective cervical cancer screening test. Now, some students said that the question is most cost-effective. Some of them said that the question is the cheapest. So, whether they are talking about most cost-effective or whether they are talking about cheapest, your answer is visual inspection with acetic acid. So, in our camps and in rural settings, we do not go for pap smear. Pap smear again is a little expensive option. We go for visual inspection with acetic acid, which is done by applying 3 to 5% acetic acid on the cervix. Now, when you apply 3 to 5% acetic acid on the cervix, the areas where dysplasia is present, they will appear as white. So, wherever dysplastic epithelium is present, it appears as white stained area, right? And these are called as aceto-white areas. So, you have to take biopsy from these areas, right? So, I will look at the cervix, I will paint it with 3 to 5% acetic acid, and wherever white areas appear, I am going to take biopsy from that area. Red area is, or the pinkish colored area is the normal area. So, unstained area is normal and the white stained area is abnormal. You have to take biopsy from the white stained area. On the other hand, if you are doing visual inspection with Lugol's iodine, right? Now, whenever you apply Lugol's iodine to normal epithelium will take brown color. So, normal epithelium would be stained, whereas the dysplastic epithelium will appear yellowish in color, right? So, dysplastic epithelium is unstained area. Over here, can you see? This is the dysplastic epithelium, and this dysplastic epithelium is unstained. It has not taken up the brown stain. So, when you apply Lugol's iodine, you have to take biopsy from the unstained area, right? Stained area over here is normal. So, in this case, the stained area is normal. So, that's the opposite of what happens with when you apply acetic acid. In acetic acid, you have to take biopsy from the stained area. Whereas, when you apply Lugol's iodine, you have to take biopsy from the unstained area, right? The other options which were given to you were pap smear. Pap smear is, it's the most commonly used method for cervical cancer screening, but it is not the most cost-effective method, but it is the most specific method, right? On the other hand, HPV DNA testing is the most sensitive method. And HPV DNA testing, it begins at more than equal to 30 years of age. Colposcopy is not a cervical cancer screening tool. It is a diagnostic tool for cervical cancer and for CIN, right? So your answer over here is VIA. Next question, which of the following have false positive bar body? So first you have to understand what do you mean by a false positive bar body. See, bar body, number of bar body, all of you know, is number of X chromosomes minus 1, right? So in males, usually the number of bar body is 0, right? Because their chromosome number is 46XY. Whereas in females, the chromosome number is 46XX. So the number of bar body is 1. So I expect that in all females, the number of bar bodies should be 1, and in all males, the number of bar bodies should be 0. But suppose if there is a male, right? Suppose if there is a male in whom bar body is positive, right? Then we are going to call it as false positive bar body. False positive bar body, right? And this is the case which is seen in Klinefelter syndrome. In Klinefelter syndrome, chromosome number is 47XXY. Now, because Y chromosome is present, that is why I am saying that they are males. But in these males, because 2 X chromosomes are present, that is why they have 1 bar body. So this is a false positive bar body, which means that the person is not a female, but still they have bar bodies. Similarly, if they ask you false negative bar body. Now, false negative means that normally negative should be a male. But suppose there is a female in whom there is no bar body, right? So false negative means a female with no bar body, right? And what is the example of such a female? Turner's syndrome. Turner's syndrome, the chromosome number is 45XO. Because they do not have Y chromosome, that is why they are females. But because they have only 1 X chromosome, the number of bar body is 0. And this is precisely the reason why that bar body is not the best method for sex determination. And this is something which I have been repeatedly telling you in my classes. Right? So the answer over here is Klinefelter syndrome. In androgen insensitivity syndrome, chromosome number is 46XY. So they do not have any bar body. So that is not a case of false positive bar body. Trisomy 21 is a autosomal problem. Here there is 1 extra chromosome number 21 that has no relation to sex chromosomes. It's not a sex chromosome disorder, and that is why you will not get a false positive bar body here. Clear to all of you? Next, a mother brings her 18-year-old daughter to gynaeopathy with complaint of not attained menarche. So she's 18 years, she's not attained menarche. Hormonal levels show normal LH and FSH. Examination shows normal breast development and pubic hair development. Ultrasound shows small blind vagina, absent uterus. Karyotype is 46XX. What is the likely diagnosis? So some students were saying that the karyotype was given, and some students were saying that ovary is present was given. Right? Now, if karyotype is given or ovary is present is given, the question becomes really very easy. If they say karyotype is 46XX, it cannot be a case of Turner's syndrome, because in Turner's syndrome, chromosome number is 45XO. It cannot be a case of androgen insensitivity syndrome because the karyotype is 46XY. And in Mullerian agenesis, chromosome number is 46XX. So it is a case of Mullerian agenesis, or in the options, MRKH would have been written. Mayer-Rokitansky-Kuster-Hauser syndrome would have been written. Right? So based on chromosome number, I can make a diagnosis. Suppose the chromosome number, the karyotype was not given, still I could make a diagnosis. Why? Because in Turner's syndrome, uterus is present. Over here, the question is saying uterus is absent. That is why it cannot be a case of Turner's syndrome, number 1. Number 2, in case of Turner's syndrome, the levels of estrogen are less. Because the levels of estrogen are less, because the gonads, that is the ovaries, are not functioning properly. They are streak gonads. So secondary sexual characteristics should be absent, whereas the question was saying normal breast development. Third thing, in case of Turner's syndrome, because the levels of estrogen are less, so the feedback, the negative feedback on FSH is no longer there. So the levels of FSH should have been raised. Here the question is saying the levels of FSH are normal. So we are ruling out Turner's syndrome, right? Why is it not a case of androgen insensitivity? In androgen insensitivity, yes, uterus is absent, that is right. But in androgen insensitivity syndrome, breast development is proper, but pubic hair development is not there. Pubic hair development is absent, right? So in androgen insensitivity syndrome, typically you get a question that breast development corresponds to Tanner stage 4 or 5, but pubic hair and axillary hair corresponds to Tanner stage 1 and 2. And here they are saying there is normal breast development and pubic hair development. So again, it cannot be a case of androgen insensitivity syndrome, and we come to Mullerian agenesis as our answer. In Mullerian agenesis, because the Mullerian ducts are absent, so the genital ridge is absolutely normal, and because genital ridge is normal, ovaries are normal, right? And because ovaries are normal, estrogen is normal, and because estrogen is normal, secondary sexual characteristics are normal, and that is why the levels of FSH are also normal, because estrogen is normal, right? So it is a case of Mullerian agenesis. Next question. A 25-year-old female attends gynae OPD with complaint of secondary amenorrhea. She has history of previous DNC and her FSH levels are 6 international units per liter. Please remember that if FSH levels are less than 10, then they are normal. So in this case, the FSH levels are normal and there is previous history of DNC. Right? So with this background, we will have to see what options have been given. The first option which was given to you was Sheehan syndrome. In Sheehan syndrome, there is necrosis of the anterior pituitary gland. Now, because there is necrosis of the anterior pituitary gland, so the levels of FSH will decrease and the levels of LH will decrease, right? So, postpartum necrosis of anterior pituitary gland, that is what is Sheehan syndrome. And if anterior pituitary gland is necrosed, the levels of LH and FSH will be less. Right? And over here the question is saying that the FSH levels are normal, so it cannot be Sheehan syndrome. One or two important points which I have to mention to you about Sheehan syndrome is that in Sheehan syndrome, the most common complaint of the patient is failure to lactate. So the question will say that after delivery, patient was unable to lactate. That's the most common complaint which you get. And the second most common complaint is amenorrhea, right? But then, suppose if you have a question on prolactinoma or increased prolactin levels, right? Now, increased prolactin levels, if they ask you what is the most common presentation, please do not say that the most common presentation is galactorrhea. No. In Sheehan syndrome, the most common presentation is failure to lactate, but in prolactinoma or hyperprolactinemia, the most common complaint of the patient is amenorrhea. And the second most common complaint is infertility. Now, why amenorrhea happens? Amenorrhea happens because whenever the prolactin levels are raised, they have a negative feedback on GnRH, and the levels of GnRH will decrease. So, the levels of LH and FSH will decrease, and that is why there will be amenorrhea. And some students said that this was also a question which was asked, that what is the reason for lactational amenorrhea? The reason for lactational amenorrhea is negative feedback of prolactin on GnRH, right? So over here, it is not a case of Sheehan syndrome. Let's talk about premature ovarian failure. Now, if there is an ovarian failure, definitely the levels of estrogen will decrease, and because the levels of estrogen will decrease, the negative feedback on FSH would be gone, and so the levels of FSH will increase and they will become more than 40 international units, and that is why this is not a case of premature ovarian failure, because here the levels of FSH are in normal range, right? Then third is pregnancy. Now, in case of pregnancy, what happens to LH and FSH? In case of pregnancy, the levels of estrogen are high, right? So the placenta is synthesizing estrogen, and because the levels of estrogen are high, there will be a negative feedback on FSH, so the levels of FSH will be low. Right, so the levels of FSH and LH are low throughout pregnancy, and that is why it cannot be a case of pregnancy also. Right, so we are left with Asherman syndrome. What happens in Asherman syndrome? In Asherman syndrome, there are adhesions which are found inside the uterus, and why does Asherman syndrome happen? Asherman syndrome happens because of excessive curettage. Now, in this case, patient is giving you history of previous dilatation and curettage, and in case of Asherman syndrome, because the problem is at the level of uterus, there is no problem at the level of ovary, no problem at the level of pituitary, no problem at the level of hypothalamus. That is why the levels of FSH and LH would be normal. So this over here is typically a case of Asherman syndrome. In Asherman syndrome, you have to remember what is the most common presentation of Asherman syndrome. Most common presentation of Asherman syndrome is amenorrhea followed by hypomenorrhea. What is the most common reason for Asherman syndrome? It is excessive curettage, which is done in the postpartum period. What is the investigation of choice for Asherman syndrome? Hysteroscopy. What is the management of choice? Hysteroscope, esthesiolysis, followed by insertion of a balloon catheter. Right, a pediatric Foley's catheter generally we do. We insert a pediatric Foley's catheter so that the adhesions do not form again, and because we want to build up the endometrium, we give them estrogen and progesterone therapy, right? Okay. Next question. A 16-year-old female visits gynae OPD with complaint of cyclical abdominal pain and history of no menarche. Her general examination shows normal breast development and pubic hair development. Local examination shows bluish bulging hymen as shown in the image. This, I am not sure whether this particular image was there or not, but there was an image of bulging hymen. On per rectal examination, uterus is palpable. The most appropriate management in this case is. So over here, the question is itself telling you that there is a bulging bluish hymen, which means it is a case of imperforate hymen. In patients of imperforate hymen, everything would be normal. Their secondary sexual characteristics will be normal because the problem is at the level of hymen. There is no problem at the level of ovary, no problem at the level of uterus. Such females will be menstruating normally, but because there is no opening in the hymen, that is why menstrual blood will not come out, and such females will say that they experience cyclical abdominal pain every month, but they do not have any periods. And when you will do a local examination, you will see a bluish bulging hymen because blood would have collected in the vagina and in the uterus. In the vagina, when blood collects, that is hematocolpos, and in the uterus, when it collects, that is hematometra. Now, because of hematocolpos and hematometra, they can press against the urethra. So patient may also present to you with urinary obstruction. Right, so please remember that imperforate hymen patient can present to you with urinary complications like urinary obstruction, also urinary retention. Right, now whenever you get a patient of imperforate hymen, the best management is you have to give a cruciate incision on the hymen and the problem is solved. Please remember that one more condition can lead to a similar picture, and that is transverse vaginal septum. in transverse vaginal septum and in imperforate hymen. In both these conditions, you can get a similar picture where the menstrual blood is unable to come out, right? Patient menstruates normally, but menstrual blood is unable to come out, and this is what is called as cryptomenorrhea. So there are two reasons for cryptomenorrhea. How are you going to differentiate between them? See, problem imperforate hymen, the problem is that there is no opening in the hymen, right? So the problem is at the level of hymen. Whereas a transverse vaginal septa, the problem is in the vagina, and generally this transverse vaginal septa is located in the upper vagina. Right? So this is located at upper vagina. So if you see over here in transverse vaginal septum, a part of the vagina will be visible. Whereas over here, this is just at the opening of the vagina. So no vagina is visible in imperforate hymen. Number one. Number two, in case of imperforate hymen, hymen is a thin membrane. Right? And when blood collects behind the membrane, this membrane will bulge out. So if you are seeing a bulging out membrane, it has to be imperforate hymen. Whereas transverse vaginal septum is a fibrous tissue. And when blood will collect behind it, you will not see any bulging out. Right? So you will see a thick fibrous tissue. Over here, you are seeing a transparent membrane, bluish colored membrane, which is bulging out. Right? Number three, in case of imperforate hymen, if you ask the patient to cough, you will get a cough impulse will be present. Whereas in transverse vaginal septum, because it is a septum, that is why when the patient will cough, no cough impulse will be present. Right? So these are the three ways in which you can differentiate between imperforate hymen and transverse vaginal septum. Clear? Okay. Next question. A 55-year-old postmenopausal female attends OBGY clinic with history of chronic pelvic pain, and X-ray pelvis shows the following image. The most likely diagnosis is. So over here you are seeing an image where you are seeing a pelvic mass which is calcified, right? Now at 55 years in a postmenopausal female, if you see a calcified pelvic mass, most probably it is a calcified fibroid. Because fibroids, they undergo degeneration, right? And one of the degenerations which can happen in a fibroid is calcareous degeneration, and calcareous degeneration is more common in a subserosal fibroid. Right? So when you do an X-ray, you get a popcorn calcification like image. Now, it could have been an ovarian mass, but in ovarian masses, the mass which shows calcification is a dermoid cyst. And number one, dermoid cyst is uncommon at 55 years of age. And number two, when you see the X-ray of a dermoid cyst, the calcification can appear in two manners. Number one, you can get calcification due to a tooth. The dermoid cyst might have a tooth, because of which you can see a calcification. And number two, in dermoid cyst, you get an area from which these tooth and these hair arise, which is called as Rokitansky protuberance. And this Rokitansky protuberance can also appear as a calcified area on X-ray, but then that will be on one side, right? This type of calcification, which you are getting a uniform calcification, a homogeneous calcification, this cannot be seen in a dermoid cyst. Then bladder stone. So number one, if you are getting this huge bladder stone which has got homogeneous calcification, definitely patient is going to complain to you of some urinary symptoms, right? So over here patient doesn't have any urinary symptoms, and this is too huge a calcification to be seen with a urinary stone which is asymptomatic, right? So it is not a case of bladder stone also. Clear? And yes, a bladder stone will be located a little more towards the center, right? It will be centrally located, and this mass over here is eccentrically located. So your answer over there was a calcified fibroid. Now, a female after delivery complains of cramps during breastfeeding. Which of the following hormone is responsible for it? Now, all of you know that the hormone which is responsible for milk production is calcitonin, but the one which is responsible for milk ejection, that is galactokinesis, is oxytocin, right? And oxytocin, it brings about uterine contractions. So because oxytocin brings about uterine contractions, that is why cramps are felt. So just because breastfeeding is given, that is why you're not going to mark the answer as prolactin. Your answer will be oxytocin, which is a milk ejecting hormone, and because of that, cramps are felt, right? Okay. Next question, a 25-year-old female and her husband present to infertility clinic. The semen analysis is normal, but HSG shows distal dilatation of the tube. On taking proper history, female complains of menorrhagia. The most likely cause of infertility is. So over here, when an HSG was done, you got distal dilatation. You got an image, maybe something like this. The image was not given, but they're saying distal dilatation was present. Right? So over here, suppose it was a case of tubal spasm. Now when tubal spasm occurs, when there is spasm of the tube, the dye is unable to move forward, and that is why you get proximal blockage. You get a bilateral proximal block in case of spasm. A spasm will never present to you with distal block, right? So it is not a case of spasm. Now suppose if it is a tubal polyp, right? So suppose if there is a polyp over here. Now if there is a polyp and if I pass a dye, what is going to happen? The dye is going to go around the polyp and inside the tube. So now when you get an HSG, the dye will be everywhere except where the polyp was, and this will be seen as a filling defect. So a polyp is going to give you an image of a filling defect. It will never give you an image of distal dilatation of the tube, right? So distal dilatation of the tube means that the fimbrial end of the tube is blocked, and that is why you are getting dilatation, right? Now, distal dilatation of the tube, it can be seen in tuberculosis and it can be seen in salpingitis both, although tuberculosis mostly it presents with bilateral cornual block. The most common finding which you are going to get is a bilateral cornual block with genital tuberculosis and not a distal block. Distal block is most commonly seen with gonorrhea. The most common cause of bilateral distal block is a gonorrhea and not tuberculosis, number one. Number two, still you can get a distal block in tuberculosis, but I am saying the answer is salpingitis and not tuberculosis, because in the options, in the question it was given that the patient is presenting to you with menorrhagia. In case of genital tuberculosis, patient presents to you with menstrual irregularity, but the most common menstrual irregularity which is seen in case of genital tuberculosis is amenorrhea followed by oligomenorrhea. Right? In case of PID or salpingitis, yes, menorrhagia is a complaint. Right? So over here, your answer is going to be salpingitis or PID, and it will not be a genital tuberculosis. Clear to all of you? Okay. Next question. A 55-year-old female is found to have cancer cervix stage 3B. The best management in this case would be, see, cancer cervix staging had undergone a change, and I have always told you the new staging for cancer cervix. So quickly, I want all of you to revise in your mind the staging of cancer cervix. The broad staging of cancer cervix is, stage 1 cancer cervix is when cancer is limited to cervix. Right, in which we have A and B. A means it is a micro-invasive cancer, less than 5 millimeters in depth. B means it's a macroscopic cancer, more than 5 millimeters in depth. Now, B was then divided into B1, B2 and B3. B1 means less than 2 centimeters in size. This is the size of the tumor now. B2 means 2 to 4 centimeters in size, and B3 means more than equal to 4 centimeters in size. Right? Then we have stage 2. Stage 2 means that now the cancer has involved upper 2/3 of vagina, right? Upper 2/3 of vagina, and again we have A and B. A means that parametrium is not involved and B means parametrium is involved, right? Now in A again we have A1 and A2, where A is less than 4 centimeters in size, A2 is more than equal to 4 centimeters in size. Then you have stage 3. In stage 3, cancer involves the lower 1/3 of vagina, right? Here also we have A, B and C. What is A? A means when the side walls are not involved. B means side wall is involved or if ureter is involved. And in C we have C1 and C2. C1 means pelvic lymph nodes involved. C2 means para-aortic lymph nodes involved. Right? So this is a broad broad staging for cancer cervix. Now in cancer cervix management, you have to remember, for management of cancer cervix, you have to remember that surgery can be done only if tumor is less than 4 centimeters in size, and second thing is surgery can be done only if parametrium or structures below that are not involved. Right? In other words, if I ask you, mark the stages where surgery can be done, you will say, ma'am, stage 1 surgery can be done, stage 1A, and 1A is further divided into 1A1, 1A2, so it can be done in both of them. In stage B, in B1 it can be done, in B2 it can be done, it cannot be done in B3. And in case of stage 2, it can be done in stage 2A1. It cannot be done in stage 2A2 and beyond that, because in stage 2A2 the size is more than 4 centimeters, so we cannot do surgery. When parametrium is involved, we cannot do surgery, and any structure below that is involved, we cannot do surgery. Right? So remember, when can you do surgery? You can do surgery in case of cancer cervix only from stage 1A1 to stage 2A1. You can do surgery, except in stage 1B3, because in 1B3 the size of the tumor is more than 4 centimeters, right? And from stage 2A2 onwards, plus in 1B3, the treatment of choice is chemoradiation, that is concurrent chemotherapy and radiotherapy, and the therapeutic agent of choice is cisplatin. If cisplatin is not available, then 5-fluorouracil. Right? So over here your question was asking that the cancer is stage 3B. So I told you from stage 2A2 onwards, you always have to do chemoradiation. So in stage 3B, you have to do a chemoradiation. Now when you are doing radiotherapy, please remember बच्चों, जब हम radiotherapy करेंगे, then first we are going to give them external radio beam therapy followed by brachytherapy. Right? Whenever you are giving radiotherapy in cancer cervix, that is what you do. Why I am telling you this is because in one of the options it was written intracavitary brachytherapy followed by external beam radiation. That is also wrong. It's the other way round. So over here the answer is concurrent chemoradiation. Right? Easy. From stage 1A1 to 2A1 except 1B3, you have to do surgery. 1B3, then 2A2 onwards, everywhere you have to go for chemoradiation. Clear? Okay. Now the last question is, a 60-year-old hypertensive female complains of prolapse. What is the best management? Now female is 60-year-old, she has prolapse and she has hypertension. So obviously I cannot do a surgery where a long anesthesia has to be given, because anesthetists are not going to take any risk. Right? So I cannot go for hysterectomy. I cannot go for a sling surgery, because again sling surgery has to be done under anesthesia, and sling surgery is done only in those females who want to preserve their fertility. Here she's a 60-year-old female, so I'm not going to go for a sling surgery. So I am going to go for Lefort colpoclysis. What do you do in a Lefort colpoclysis? In a Lefort colpoclysis, under local anesthesia, you do a curettage of the anterior and the posterior wall of vagina, and because you've done a vigorous curettage of the anterior and posterior wall of vagina, adhesions will be formed and prolapse, the part which is prolapse will not come out, right? Because you have closed the vagina. That is what is Lefort's colpoclysis. And females who are more than 60 years, they are postmenopausal. That is why we can go for Lefort's colpoclysis in them. Lefort's colpoclysis cannot be done in young females because number one, they, every month, where will the menstrual blood go then? If you are closing both the anterior and the posterior vaginal walls, how is the menstrual blood going to come out? And number two, how are they going to perform their coital function, right? That is why in young females, we do not have the option for Lefort's colpoclysis, but in a female 60 years who's hypertensive, we have the option of doing Lefort's colpoclysis, right? So that brings us to the end of discussion today, and seriously, but so on a very serious note, OBGY questions, there were many questions, but the questions were very easy. So that is repeatedly I tell all the FMGE students that obs and gynae is one subject which you should do very nicely for your MCI screening test, because you get a number of questions from them, and all questions are easy questions, concept based questions if you've understood the concept well. So please focus always on understanding concept rather than mugging up obs and gynae. Take care, all the best for your results. Thank you.